Hello everyone. The topic we'll take now is teeth selection and its arrangement. So what have we done till now? What we have done is all the first and foremost we have made the primary impressions. Then what we have done, we have taken the border molding, we have made the secondary impression or the final impression. Then we followed by pouring the cast, making the master cast out of it, then doing the jaw relation or the maxillomandibular relation that we saw. Now what is the main aim of doing all this thing is to arrange the teeth. So now we have to select what kind of teeth for what patients and also how is and which teeth is arranged. So coming to the teeth selection and arrangements of the teeth. The first important is denture aesthetics. We all know that a patient's requirement for a denture is only two purposes. Maybe because of the aesthetics or maybe because of the mastication, that is the further occlusion. So for both the things, we need to decide that which kind of teeth we are going to place and where and which teeth is going to come. Like for example, how is central incisor going to be there? How is the laterals going to be there? How are the canines going to be placed? All these have to be decided by the dentist for say. So the cosmetic importance is also there as well as the occlusal importance is also there. Not only that it is aesthetically important, but also it is important for the occlusion of the patient to know and select the proper teeth. So what are the guidelines for anterior teeth selection? Now what all we can use for selecting an anterior, that is if the patient has come to you before extraction, we must have an extraction records. For example, we can have cast, we might have their photographs, we might have their radiographs, we might have the silhouettes. All these can aid to the selection of the teeth for that particular patient. Now personal patients, like for example, a patient of maybe a age of younger 40 to 45 who has lost all his teeth for poor periodontal support or any caries regions, now that person wants the teeth how it was before, not an ideal Bollywood and Hollywood smile kind of teeth. So for that we need to have the older pictures of that particular patient. Also a cast will also do, so to measure the sizes of the teeth and also to see the position of the teeth which is seen and visible from the front, the anterior teeth basically. So selection of anterior teeth is foremost most important and rather than the posterior teeth selection. And the posterior teeth selection will play importance in what? So it will play importance in the occlusion of the particular patient. Post-extraction examination of the patient, like edentulous patient when coming to you, can also be examined. Now the teeth selection doesn't only matter and advocate the cosmetic appearance or the occlusion, but also it depends on the ridge shape and size. Form of the ridge is very important in that case. Now shape of the face, as per Sir William said, what did he say? That every person's face is different. It can be square, it can be tapering, it can be ovoid. So let the teeth shape of every person be different. A square person, let him have a squarish shape of teeth, central incisors, laterals or canines. Let that person have a rounded shape which of the teeth whose face is also round. Now that looks pretty good and more concerning with the aesthetics. Rather than aesthetics and to that of the person's look, the personality of the person also varies. Now the person who is into modeling or a straight triggered person, for them a squarish teeth looks good. A well-spoken or a soft-spoken kind of person, a little roundish kind of teeth is better. For those who are females, for them, they do not like to have those sharp-edged central incisors or canines. They look very vigorous in those. So we need to modify the shape and sizes of the teeth according to the patient and their needs. Coming initially to the sizes of the teeth. Sizes of the teeth, as from history it comes over, like measurements were taken, measurements of what? We had taken bizygomatic width, we have taken bigonial widths, we have also measured the central incisor width along with bizygomatic. That says that bizygomatic width is equal to 1 upon 16 times that of width of central incisor. Similarly, they said that if we divide by zygomatic width with 3.3, we will get the width of all the anterior teeth. So then Pound came over, he said the distance between the zygoma will be upon 16 will give you the central incisor width. The length of the central incisor, he said that measure the length of the face divided by 16, then you will get the length of the central incisor. So selection of the anterior teeth was more based on the shape of the face of that particular patient which is coming to you. Now the size of the face, how do we measure the size of the face? Now the size of the face was measured with an instrument which had come over in very earlier times in the history of dentistry, was tribute or trubite tooth indicator. Now this trubite tooth indicator which was placed, it was like a silhouette. It used to be placed, it had two marker points. So it will mark the measure the face from the chin line to that of the hairline. Now that is how we had measured the size of the face. Divide by 16 will give you the length of the central incisor as told by Dr. Pound. Coming to maxillomandibular relationship. Now once we are doing the maxillomandibular relationship, that time when vertical dimension at occlusion was measured, so that has got typical type of size. So the amount of size that time it was measured is y is an anterior length of wax rim 21 to 22 mm, whereas that of posteriors is 18 to 16 mm. So the reason lies here because the length of the central incisor that we are going to use is around 21 to 25 mm. Coming to the size of the maxillary arch, we have told earlier as well during we were learning about the retention and stability support that the size of the maxillary arch is around 24 centimeters square, whereas that of mandible was around 14 or 16 centimeters square. So that will also decide, like from the incisive papilla to that of the maxillary tuberosity, if you mark a line, and from maxillary tuberosity to the other of tuberosity, that will give you the entire area of the maxillary arch. Similarly, from canine eminence to the other canine eminence, that will give us the anterior length of the teeth that you are supposed to use. The width of the anterior teeth will be all decided with this. Coming to the contours of the residual ridge. Now if we have a V-shaped ridge, the teeth is also to be V-shaped. If we have a U round proper shape, so we can arrange our teeth over, because teeth should be over the ridges or maximum in the neutral zone. Near about it is onto the ridge. It cannot be that a patient's ridge is V-shaped and you are arranging a teeth in a U shape. That is not possible. The vertical distance between the ridge plays a very important role. Now interarch distance, that should be around 25 mm, that also decides the amount of teeth that we are going to use. Now a person from before only has a less interarch space. We cannot give just because his face is big that the central incisors will be big. How will the occlusion come then? So we have to accommodate both the maxillary arch teeth as well as that of mandibular arch. So we need to have a proper sizes of the teeth. Coming to the lips per se, the lips competence is also important. How is that? The lip length. If a person is having a short lip length, that is this to this area, that is subnasally to that of the lower part of the vermilion border. If that is short, the gummy smile will come into picture. So we can use a little longer kind of teeth so that the gummy smile is hidden by our arrangement of the teeth. So that is how lips play important role. So methods using theoretical concepts came over, like Winkler's concept. Winkler said that teeth selection is based on that of the physiological or the facial musculature. He said that by looking at the patient after putting your teeth and your wax rims, if these muscles are not relaxed down and it doesn't have wrinkles, that means your teeth selected and your amount of vertical dimension at occlusion selected is perfect. So that is how Winkler advocated his technique of using and selecting teeth based on the biomechanical views, and like you have to ask the patient to talk and then you have to see how comfortable the patient is. Ask the patient to occlude and see if these are getting wrinkled out. That means there is still more chance that you can increase the vertical dimension of the patient. Coming to Williams classification, he said opposite that of the face. That means if a patient has a face of square tapering, let the teeth be opposite, tapering square. opposite that of the face. Always remember for the Williams concept, that is opposite to that of the face. Coming to patient's profile, he said that if we look the patient from a side view, that is how we are seeing the profile of the patient. So when we will see the profile of the patient, that will decide the curvature of the teeth. Now if the patient has a convex profile, let us keep the teeth also convex. Opposite goes and vice versa goes same for the concave. Patient has a concave teeth, concave facial profile, so let's keep the teeth as well concave. So because what happens, if the patient has a protruded mandible and you keep the teeth retruded, it will look again aesthetically very unpleasing. Color of the anterior teeth is another important thing that we need to know and decide. And how are we going to decide for this color of the teeth? Is it based on the hair color? Is it based on the eye color? Is it based on the skin color? It is based on the entire color of the patient. It is not necessary that every patient will want its teeth to look like a very white sparkling smile. No. A patient who is darker in color will not appreciate having a white teeth on his mouth. While he's speaking, so those teeth gets in center of attraction. A patient who is fairer in his skin tone will not appreciate of having yellowish tinge of teeth present in his mouth, because he doesn't want that to be the low value for his cosmetic index. So cosmetic index basically plays a very important role in shade matching, color matching. Now what is a test that we do to match the color for the teeth? That is called squint test. How we do it, the squint test? We close one eye and then we see the patient's skin color. The color which fades the first is the color that we are supposed to leave. The color which remains till the last is the color of the patient that we are supposed to take. Now, and before all this thing, the tooth color is also different. The neck of the tooth will have some different color. The incisal edge has little translucency in it. There has to be one opacity when it comes to the middle part of the teeth. So every color has a different shade. So any teeth, if you divide into 6 quadrants, for example, first, second, third, fourth, fifth, 6 quadrants, then every quadrant will have different color. So while we are sending this color to that of lab, it's very good practice for yourself to mark those quadrants and mark the color exactly. Before checking all these colors, we need to know certain science behind that. That is, the anterior teeth will always be lighter and the posterior will be darker. And why is that so? Because we know that our mouth is black in color when you see from behind. So the contrast in the backer side, the light will not enter too much as it is coming to the incisor to that of the molar. So molars will look little darker than that of incisors, number 1. Number 2, when you are using a shade guide to match the shade of the patient, do not forget to moist the shade guide as well as moist the teeth before looking over the shade, because saliva is something which is predominant in our mouth. We cannot avoid that. So let the shade be along with the saliva of the patient as well as moistening the shade guide. One more important thing is, with age you need to know that typically the shade gets lighter, A 3.5, it goes to C1 at times, C2 very darkly. So this is how you need to see and visualize the color of the patient, and that is how you are gonna supposed to decide for the color of the teeth that you're gonna arrange. Coming to the next, that is dentogenic concept, also known as dynaesthetics, also known as Frushing-Fisher technique, also known as SPA factor, also known as sex, personality, age factor for selection of anterior teeth. Now what are all these? Dynaesthetic, dentogenic, Frushing-Fisher, who are they? Why did they come across? How did they come across? They said anterior teeth selection is combination of 3 factors. A sex of the person is going to decide, the personality of the person is going to decide, the age of the person is going to decide the selection of the anterior teeth. Now coming to the first factor, that is the sex of the patient. Now a male patient and a female patient have typically different kinds of teeth. A male patient will have a teeth which is more squarish, a patient size of the teeth will be bigger, The incisal edges and the line angles will be sharp. There will be no curvatures in the teeth. Whereas that of a female, a patient's teeth will be more curved. The line angles will be smooth. The teeth will be almost rounded in its border. The incisors can have a bit of mesial tilts then to that of the on the next teeth, that is if this is a central incisor, you can have a overlapping lateral incisor mesially onto that of central incisor. It looks very beautiful in a female. So sex of the person determines the selection of the teeth. Coming to the canines, like mesial third of the canine if a female should be visible, whereas for a male teeth can be visible till middle two-third. This is reason because the lip curvature of the males is more than that of females. So for females, the arrangement of the canine line should be limited to the mesial half, whereas the canine line for the male should be till the two-third of that of the canine. Cervical portion, is it visible? It is visible more in cases of that of the female patients, whereas in males what will happen, you have to make it more vigorous, so that time you have to keep a body shift of the entire canine, or you can keep the canine incisal edge outside, so that will give a vigorous look to the particular patient, a Dracula kind of look. So personality of the patient also matters. Now how is that? What can be different personalities of the patient? A patient can be delicate, a patient can be soft spoken. So for them, the teeth has to be rounded, the teeth has to be no sharp edges, the teeth has to be very smooth in its curvature along the axis. That is, curvature along the axis matlab the curvature should be along with the ridge and there should be not any sharp turns. Then coming to medium pleasing, any kind of teeth goes good with them. Whereas for a vigorous kind of patient, you need to have large teeth, visibly big teeth, squarish teeth in nature, and the line angles and the point angles will be sharpened enough to give that vigorous look in the particular patient. So that is all how we understand with the difference in vigorous and delicate kind of people. Coming to the age factor, we all know as the age proceeds and geriatrism comes into picture, that time the skin tones also decreases, tonicity decreases, the color shade of the skin decreases. So in that case, why will the teeth look very whiter and fairer in color? Even the color of the teeth will decrease. It will decrease from the shade of A1 to that of A3.5. It will decrease from the shade of B2 to that of C1. So this is how with age the color of the particular teeth also decreases. Now natural teeth, let's compare this with the natural teeth. When age occurs, we have atresion, we have abrasions, we have all the water fluid contents coming into picture and acting over it. All the acidic exposure is there onto the teeth. So what is it making the teeth more yellowish, more exposed? So that is the reason we need to give the teeth of that kind in an artificial denture as well. Also, interdental papilla plays an important role. For young, the interdental papilla will be in the ICP, that is the intercontact position, whereas that in the older age, the interdental papilla and everything will recede back. So you can have little space between the papilla and that of the contact point. They can be, you can show all these characteristics and even in your denture to make it look more natural and pleasing appearance. Coming to the posterior teeth selection. Now, posterior teeth is more important for occlusion. So what are the things that we need to see over there? What type of occlusion that we are going to give? What is the shape of the teeth? What should be the size of the teeth? Now that will depend on the width of the ridge. What should be the form of the teeth? Now that will depend on how much is the curvature behind of the particular ridge of the patient, and also the space that is present to us. So those are ones which are going to decide. Now type of teeth, as in type of teeth, that means that it can be monoplane teeth, 0 degree, no cusp. It can have 20 degree cusp. It can also have anatomic teeth like 33 degree cusp for those who have a good interarch space. Interarch space is compromised, you need to compromise on also the teeth size and the shape of the teeth. Coming to the materials for artificial teeth that we can use. The older and earlier material that was used still was porcelain teeth. Then came up the resin teeth and also metal insert teeth. Now this porcelain teeth which was there in the earlier time, it had certain disadvantages. It also had advantages. The chewing efficiency was excellent. They had no complaints about occlusion. They had no complaints about mastication. But the complaint which remained was that clicking sound all the time. The complaint which remained was the resorption of the ridge which was taking place again and again in a faster duration. The complaint remained was that those porcelain teeth was hard teeth. All these were replaced by the IPN. IPN is what? Interpenetrating network teeth, which is the resin teeth in these days. So we have this synthetic resin teeth now. They are good enough, they are lightweighted, they are good, they have a good amount of chewing efficiency because they all work in a motor pacil activity. But what is the disadvantage? Now those teeth are resin teeth. They get abraded very easily. So that's one of the disadvantages of those kind of teeth. Metal insert, why do you need to insert a metal inside the teeth? For good retention and also little more strength to that of the material. So teeth types, I spoke already about this. Anatomic teeth, that is the 33-degree teeth, the cusp angle will be 33 degree. Non-anatomic teeth, that is 0-degree teeth. Then come cuspless teeth, there is no cusp, monoplane kind of teeth. 0-degree teeth, all these other names for the non-anatomic teeth. There is one teeth in between that is called the 30-degree teeth. Turner and Plinton's teeth, that is a 30-degree, 20 to 30-degree teeth. Coming to the arrangement of the teeth, now there is science behind some arrangements as well. Why there has to be science behind an arrangement? Arrangement can be because of the patient, how the patient's curvature is, but no, not always. Always you need to follow the science behind that. That is, how the smile line is of the patient. How is the patient's curve of speed? You need to arrange the teeth also according to that. If you arrange all the teeth in one level, it will not follow the curve of speed. Today it will be good, tomorrow it will not follow the proper movement of the mandible. It will hinder them. So we need to follow all those guidelines, and that is the reason that we have different guidelines for different teeth. Coming to central incisor maxillary, it should touch the glass plate when you are arranging. Right? So that means it is the highest point on the smile line, the curve of the smile line. Then anterior teeth, maxillary, should not have much tilt on mesial or distal. Let it be straightly placed, little with the distal tilts present. No mesial tilt, of course, because if you give a mesial tilt, you are creating a diastema in between. So a bit of distal tilt like this, I am talking from the cervical end. Cervical end, distal tilt somewhere like this, little bit more with the long axis of the teeth. Coming to lateral incisors, keep it little above the central incisor. And why is that so? Because you remember, smile line is not a straight line, it's a curve. A curve is going to follow like this. So the central, after that lateral has to be little above. Now this lateral incisor, now if you place straight, you have placed the centrals like this. Now you place the lateral straight, again there will be a diastema present. So now how you are supposed to place the laterals? With some amount of again mesial tilt from the incisal edges. So we can see there is a mesial tilt present. Coming to canine, most important and most doubtful and questionable placement. Canine, the incisal tip should touch the glass plate, no doubt, because the canine, the curve line of course is going high, but our lip line is also smaller in this area. The lip is down here, smaller in this area. So when we smile, we have more visibility of canine. So canine, how is supposed to place? You have to place the cervical end little outside and the incisal end little inside. So that will give you an exact aesthetic look, because from canine the posteriors are going to turn inside. So that turning is we are supposed to make with the help of canine. So what are we supposed to do? Let's only make the mesial 2/3 of the canine visible and let the distal part not be visible. So once it is inside, so then it can take over the posterior ends of the particular teeth in the arrangement of the teeth. So that is how you have to place the maxillary canine. Coming to first premolars, I can be very sure to say, first, second, all the premolars, let all that be placed straight, because that gives a very good look, until coming to the incisal edges. Now you are supposed to keep in mind that there is something called as curve of spine. So that curve of spine follows from that of the canine tip of that of mandibular teeth to that of the retromolar pad, passing from the center of rotation of the condyle. Now that when it happens, now how is the maxillary first premolars buccal cusp and distal cusp. If we have known with the anatomy of maxillary, buccal and distal cusp, the distal cusp and buccal cusp is not much of difference. The distal cusp is little shorter in size. So of course the distal cusp will be little, I'm sorry to say, the palatal cusp will be little shorter in size. So that palatal cusp will be little on the higher side than that of the buccal cusp. Similarly, butt of that of second molar, premolar, both the cusp have a same height. So both will be touching onto that of the glass plate. Coming to that of the molars, only the mesiobuccal cusp will be touching. Rest all the cusp tips has to be little above, because now you have to follow that curve of the speed which is going like this and above. So you have to follow and start putting up the teeth little higher. So the first teeth which will be little, the cusp tip which will be higher is the distobuccal cusp. That will be little higher of the glass plate, 0.2 mm. Then coming to second molar, mesiobuccal will be 0.4 to 0.5 mm. Coming to the distobuccal of the second premolar, it will be much more higher, around 0.7 to 1 mm of height from that of the glass plate. This is how we will follow the curve of the speed which is going from down towards up. So that is the reason you need to follow these kind of arrangements in that of the maxillary teeth. Now based on these arrangements of maxillary teeth, your mandibular teeth arrangement is going to come. Now coming for say of mandibular anterior teeth, it has to be placed very straight till canine. Before till canine, all the incisors and the laterals has to be placed straight. The placement of this will also be decided with the help of the overjet and overbite that we decide in a patient. If we have a patient with a much of overjet, what will happen? The incisors, upper incisors is down and the lower incisors are up high. So it is giving a deep bite of appearance, bad appearance. We need to have exact amount of overjet, 1 mm, to overbite 0.5 mm according to the new voucher. So that is how you are supposed to place the mandibular central incisors and the lateral incisor placed straight with no curvature. Coming to the canine, it can have little mesial tilt towards the incisal edges. Now why is that important? Because canine is the first bigger teeth in that of the mandible, first bigger teeth. So if we keep it as straight, it will look very unaesthetic in part of the incisors with respect to that of canine. So once we do it little slightly towards inside, one, it is covering the area a bit more. Second is that the upper lateral and the upper canine, that is the maxillary lateral and canine, will be the interdental space of that will be covered with that of the mandibular canine. So if we place it straight, less amount of space will be there. So we can even see the premolars very nicely in the front, which doesn't look good. So that is the reason there is a canine which has little tilt onto mesial side. First premolar, second premolar, first molar and second molar, all of them has no signs of arrangement, but yes, it should be arranged according to that of the upper curve of speed which was we have created with the glass plate. Now we will arrange it with the occlusion to that. So now again we have followed the actual curve of speed based on the maxillary teeth arrangement. So now there is a big question again coming over here. Which teeth arrangement should be done first, the maxillary or the mandibular? Book says, any book, you take out Winkler, you take out Boucher, you take out Hartwell, any book says first do the mandibular teeth arrangement. Based on that you do the maxillary teeth arrangement. But the common practice as a practitioner as well as a dentist or a prosthodontist remains, you do the maxillary teeth arrangement and then go for the mandibular teeth arrangement. The reason is maxillary teeth anteriors will decide the aesthetics of the patient. Posteriors, now we know how is the curve of speed created in the mandible. Based on that of the curve of speed and the arrangement of the teeth in the maxillary, how we are taking up the premolars little higher in the palatal end, which of the molar, which cusp we are taking little higher and why we are taking, so that when those are taken higher, the mandibular, those teeth will also be little higher in the occlusion. So we are following the curve of speed as well. So it is more easier way of planning a arrangement of teeth. So that is the reason for our own ease we do the maxillary teeth arrangement first, followed by mandibular teeth arrangement. This is how a complete teeth arrangement should look, and waxing and carving of after teeth arrangement is for most importance for again aesthetic concern of the patient. That gives good aesthetics, and also aesthetic will be decided onto the matrix color, that is the denture base color. That has also to be decided. If a person is not more fairer, don't give up a red color of gingiva. let's keep it a little paler gingiva that gives more of an aesthetic appearance of the patient. So, based on the color of the mucosa of the patient, now we have to decide the matrix color of that particular patient. So, if the patient is not having very dark red gingiva, you're not supposed to give a dark color of acrylic over that. If the patient is having a little paler, choose the color little lighter in shade so that it will give more a pleasing appearance to the patient. So teeth selection foremost important, and then arrangement of the teeth. Only not science plays a role here, but also art. As the definition goes, it is the art and science in dentistry that we are supposed to consider for the teeth selection as well as arrangement of the teeth. Thank you.